lunch hour and coming in and listening to the eye talk. I am happy to answer any questions that you have. If you hold until the end, I'm less likely to get kind of discombobulated, but happy to answer any questions that you all have. I'm trying to talk about kind of the most common things that we see in eyes, here in California, just to kind of try to cover the things that you guys would be most likely to encounter with your own horses. But certainly if you have another question, I'd be happy to try to answer it. I just picked this picture because I thought, wow, that's a really cool color eye. I've never seen a horse with a blue eye quite that color, so I'm assuming that it was more kind of that whitish blue and they used some kind of reflective light to get that color, because I don't know about anybody else, I've never seen one quite that color. But I thought that was pretty neat. So just to get started, I know this brings everybody back to like, high school science, and you go, oh God, don't make me learn the, parts of the eye. But it is a little bit helpful when we're talking about, where the different issues that horses have, like uveitis or corneal ulcers and stuff, where they're occurring. And so when we're looking at an eye, we come out to look at either a normal eye for a pre-purchase exam, or we come out to look at a horse's eye is swollen shut, and we're getting the eyelids open and getting a look at things. We're obviously looking at the structures around the eye. We're looking at the conjunctiva, which is the tissue around the eye. We're looking at the bones around the eye too, to make sure there's not a fracture or something like that. This here is going to be the cornea, so we see a lot of problems in that area. That's basically that outer surface of the eye. Then in here is the anterior chamber. We will see some issues in there. Uveitis, we can see problems in that area. Then this is the iris, or the colored part of the eye. Most of your horses are going to have brown iris. Sometimes, pigs and stuff will have a blue iris. Then the lens back here, we do see horses get cataracts, and that's going to be in the lens. And then this is the back of the eye. When we're doing a fundic exam, we're looking at the back of the eye. We get the reflection, or the tapetum, which is that eye shine that you see. If you shine a flashlight in your horse's eye in the dark, you get that reflection back at you. That's coming from the tapetum here. And then the retina, obviously, is the part of the eye that actually transmits, the images that the horse sees to their brain. And then just some muscles and the optic nerve back here. And then I just wanted to show you guys too an anatomy from the front. So we'll talk sometimes about, we like to use big words, big terms. So medial canthus is going to be the inside of the eye, so his nose is here. He's got another eye here just to orient you. Medial canthus is going to be inside of the eye. Outside of the eye, our lateral canthus is going to be up there. Third eyelid, the horse's third eyelid kind of hides down here. It's actually kind of a triangular shaped structure here, and they can have issues with that third eyelid, so that's another structure that we'll sometimes need to look at. Pupil here, and this is how the light obviously travels through to the back of the eye. These are the corpora nigra. I don't know if you guys have heard of those before. That's kind of the horse's natural shade. It's like they can't wear sunglasses, so that kind of creates a little shade for them. These can have variations. Sometimes they can be larger, and they can actually be cystic sometimes, which can be a variation on normal, but if they get really big, they can sometimes obstruct a horse's vision. So on a pre-purchase exam, if we notice that they have, really enlarged corpora nigra, we might say, even though this is a normal structure, it's big, and it might affect your horse's vision, especially if it's out in the bright light and their pupil is constricted and they have almost too much of a shade hanging down. Upper eyelid, lower eyelid, you guys have got that. So, some of you may have experienced before you walk out, you see your horse has a big swollen eye, you may try to open it and look at it, you really can't get his eyelids open. Is this an emergency? And the short answer is yes, because sometimes it is and sometimes it isn't, and until we look at it, we don't know. So, so that's kind of the short answer. If you're, if you've got the eye open, partially open, sometimes you can see, like Debbie was saying earlier before we started talking, if just the conjunctiva looks swollen, it just looks like he has a conjunctivitis. You might, say, okay, well, I think I can, wait and see how this goes. But for the most part, if you've got a swollen eye, we need to see it within the day. So when we arrive, you know, we'll usually get just kind of a brief general physical exam on the horse, make sure they have good gut sounds, check their TPR, make sure they don't have a fever, and then we'll start focusing on the eye. So some of the things that we will use, because they have such strong eyelids, and once that eye is swollen and closed, they really don't want to open those eyelids for us. So we have a nerve block here called the auriculopalpebral nerve block. And what we do is we just put some lidocaine under the skin there, and that blocks the nerve for the upper eyelid, the motor nerve for the upper eyelid. So we put that in there, and then within about 3 to 4 minutes, that eyelid is pretty floppy and easy to open. And then this one over here is the supraorbital nerve block, and that blocks a portion of the sensory portion of the upper lid. So we'll sometimes block that, sometimes not. And then up here you can see this is a stain strip that we use. So if we have any concern that the horse might have a corneal ulcer, we'll use some stain material. Sometimes we'll put the strip directly in their eye. Sometimes we'll actually put the strip with some saline in a syringe and then squirt it in their eye. And the reason that we use the stain, we'll give a couple reasons. This is the primary reason. You can see here, once the outer layer of the cornea has been, the epithelium has been worn away, you'll get stain uptake. So this is evidence of a corneal ulcer here. Then another reason that we'll use the stain is someone was asking about when your horse has blocked tear ducts. You know, your horse might have a little bit of discharge in the corners of their eye. That, you know, you're constantly wiping away. The eyes are really open and normal and clear, but they always just have a little bit of goop in, you know, the corner of one or both eyes. And, you know, you guys will say, oh, why am I always cleaning my horse's eyes? And we'll say, oh, they might have a blocked tear duct. And we can put the stain in their eye, and then we can watch for the stain to come out of the little opening of that lacrimal duct at their nose. So another reason that we use the stain, but primarily if you've got a horse with a swollen eye, we're using it to see if the horse has a corneal ulcer. And then this is just an example of the ophthalmoscope that we use. It has a direct head, an indirect head, and then a magnifying piece. And so we'll use sometimes, you know, one or all of those pieces to get a look at your horse's eye. At the beginning of the exam, again, a lot of times we'll be, you know, just palpating the outer border, make sure they haven't, you know, injured the bone up here, the zygomatic arch or something. There hasn't been trauma, you know, to the face. And then usually we'll start, you know, getting further and further into the structures of the eye. So here's a list of what I consider to be kind of the most common things that we see affecting your horse's eyes. Conjunctivitis, trauma, corneal ulcers, uveitis, foreign bodies, eyelid lacerations, which is a little bit of a subset, parasites, and specifically Haberdiniasis, or what you guys probably know as summer sores, which obviously we can see all over the place, but we can see it affecting the eye as well. And then tumors of the eye, and the most common two that we see are squamous cell carcinoma and sarcoids. So to start out, conjunctivitis, this is a big one, kind of starting now, and I apologize, I wrote during spring and fall, and it's right during spring, summer and fall. So conjunctivitis is going to be inflammation of the conjunctiva, which is the tissues here, the pink tissues around the eye. And you know, when your horse's eye is normal, you almost don't notice those pink tissues. I mean, they're there, but you really almost aren't even seeing them. They're kind of tucked under the eyelid. And when they get inflamed, they get red, they get swollen. You know, you can see this horse's lower, the whole lower lid is, you know, puffed out because that conjunctiva is swollen. And we most commonly will see that conjunctivitis with allergies. We see it a lot with allergies to insects. And then also some horses just, you know, it can be an inhaled allergen, you know, something blooming in your yard or your area that your particular horse is irritated by, and they show it with the conjunctivitis. We can also see some conjunctivitis secondary to some more serious eye problems. So, like a horse that has some uveitis or a corneal ulcer might also have some secondary conjunctivitis. They're usually showing some more serious signs. So typically these guys will present with an eye that's fairly open, you'll see that swelling of the conjunctiva and usually some discharge from their eye, but they're usually holding it fairly open. And I would say most typically we'll see it bilaterally, so in both eyes. And the way we usually will treat this is with topical antibiotics, plus or minus a steroid in those antibiotics, and anti-inflammatories. So steroids are okay in an eye with conjunctivitis as long as we're not concerned that they have any kind of a corneal trauma as well. If there's any concern that there might be a scratch, then we'll usually just do the topical antibiotics without the steroid. And then anti-inflammatories, usually we're treating horses with oral systemic DVM. One of the questions earlier was what, about a horse with a blocked tear duct or blocked nasolacrimal duct. The fancy name for that is dacrocystitis, which I'm not even sure I knew, or I guess I knew at one time and then forgot, but I looked it up. And so a lot of times we'll see horses get blocked ducts secondary to a conjunctivitis. So their eyes will get inflamed from, the flies in the summertime or something that's blooming. And then they're going to be making a lot more tears, and then there's going to be, some discharge. And some of the discharge, comes out on their face, and then some of the discharge is going to go down that duct that starts at the corner of their eye and comes down out their nose. And so that kind of thick discharge will sometimes block partially or completely block that nasolacrimal duct. And sometimes just treating them with a topical antibiotic with a steroid will be enough to clear that. Sometimes we actually have to flush it, and so what we do is we take a long cannula here, and we pass it into this little nasal puncta here. We go in, it varies with horses, we usually go in an inch or two, and then we're passing saline, sometimes saline with a little bit of steroid, up through that duct, and then you'll see the horse the saline will come out their eye, the medial campus of their eye. Most horses really don't like that, so we're usually sedating them to do it. It takes a different sort of horse that'll just sit there and let you do it. I think it's just a really bizarre, uncomfortable feeling for them, so most of the time we're sedating them. And some horses really will just chronically get this issue. I don't know whether they have some scarring out their duct, and so it's just more prone to getting clogged, or whether there are horses that are just have more allergies and are more prone to getting kind of a low level of conjunctivitis. So some horses have to have their ducts flushed a couple times a year. I do have some patients that I know pretty well. We flush their ducts a couple times a year. They seem to get kind of just a chronic myoconjunctivitis. And I sometimes will have those clients just put an antibiotic with a steroid in their eye a couple times a week. And that sometimes will help to keep the ducts open. Obviously, you have to be careful not to use the eye medication with the steroid if their eye is ever closed or looks, particularly irritated, because we don't want to be using a steroid ointment if a horse ever has any kind of a corneal trauma or ulceration. But if the eye is just looking, the way it always looks, and it looks pretty normal, some folks that twice a week with that antibiotic with steroid will be enough to keep them from re-blocking that duct. So this is just a quick stop at trauma. So we were talking about, you walk out and your horse's eye is really swollen shut and you think, oh my gosh, this is something terrible. And it can be something terrible, and sometimes all it is they just really whacked their eye hard against something. And as I talked about, we check certainly the bones around the eye, diaphragmatic arch, to make sure they haven't fractured anything. If they hit the eye really hard, they can cause retinal detachment in the back of the eye. That can be very serious. They can cause a secondary uveitis. That trauma can then cause inflammation within the anterior chamber itself, and you can end up with a uveitis secondary to that trauma. But sometimes, once we get those eyelids, the eyelids themselves are really swollen, and once we get the eye open and we look at it, the eye itself looks totally normal. We'll still usually treat those horses with a topical antibiotic, sometimes with a steroid, and then the systemic anti-inflammatories, because if we get to that eye, 6 hours after he whacked it, we might see some inflammation within the globe itself in another 12 to 24 hours. So we're usually going to put them on anti-inflammatories, both to help with the swelling of the eyelid and then to hopefully prevent any of those secondary issues. And then another type of trauma obviously is penetrating trauma, so very different, but you know, if your horse obviously impales his actual globe on something, that can be much more serious. You know, sometimes we see horses that are eating in blackberry bushes get a blackberry thorn into their cornea. That can be really, really serious. Or obviously, you know, they can run into something more significant and actually completely penetrate the eye. So those are going to be much more serious situations. I had to put in a couple of pictures. So eyelid lacerations, we don't tend to treat those really significantly different than any other type of laceration. Obviously, we're going to check the globe itself and make sure that there's not any injury to the eyeball itself. We're going to treat the eyeball itself after suturing up those lacerations to make sure, again, that we don't have any secondary issues after the trauma that was in that area. These will usually close in 2 layers, so we'll usually close kind of the subcutaneous tissue and then the skin itself. It is important, though, the way that the skin edges and the eyelid edges are brought back together specifically, because if the margins of the eyelid aren't brought back together completely normally, then you can cause a problem where there's constant trauma to the eye with the irregularity of the eyelid, or if the eyelid doesn't close completely, you can end up with secondary issues like dry eye or corneal ulcers because the eyelids can't close completely. So this is just a fun little diagram of the fancy suture pattern that we have to use. So it's called a figure 8 pattern, and so here you can see we've already closed the subcutaneous tissue, and then we're doing a second layer here. And the point of it is so that this is a smooth piece of suture. This is the eyelid right here. Smooth piece of suture. We don't want any knot right here. So we do this figure 8 pattern to allow us to basically we're making a suture up here, but we're tying it down here further away from the eyelid itself to prevent any kind of scratching. Sorry.
No, you're fine.
Okay. So moving on from the eyelid lacerations to corneal ulcers, this is a big one. It's probably the most common eye problem that we see in horses. So things that you're going to see, again, you're probably going to see a swollen eye, you're going to see some discharge, the eye's going to be painful, you're going to see blepharospasm, which is the eyelids that just want to stay closed. They don't want to open up, just can't even control it. It's just holding the eye closed. You're seeing epiphora, which is excessive tearing. These are a big deal. They can lead to loss of vision, loss of the eye if they're not treated properly. You can see here we've stained this one, so we use that stain. You can see a pretty big ulcer here. And so that cornea has taken up that stain because the epithelial layer is gone. And then this one up here is without staining. Those are great big ones. Sometimes they're small, and sometimes they're hard for you to see. And so you have to have kind of a special light and a stain to see them. So they're not always just glaring at you like that. The way that we treat these guys typically is going to be antibiotics, no steroids, are, ever that I can think of that we're ever going to use a steroid, because those are going to potentially allow more bacteria to enter the ulcer. Sometimes we'll treat with antifungals if it's a fungal ulcer, anti-inflammatories for sure, so systemic Vanamine. Sometimes we'll actually be using topical anti-inflammatories as well. Mydriatics, which is atropine, which dilates the eye. So one of the other things that we see with corneal ulcers and painful conditions of the eye is that pupil will constrict. And that process is really painful for the horses and also can affect their healing. So the atropine will allow the eye to dilate. It will make the horse's eye usually more comfortable. The atropine itself is a pretty potent medication. We give it topically, but it can affect the horse's GI motility, and it can actually slow their GI motility. So we try to be fairly judicious in using it. So we'll usually have you put it in for a day or two, and then we'll sometimes discontinue or drop back to just every 3rd day or so, because we don't want them to end up with a secondary colic from the atropine. And then another one that we'll sometimes use in difficult ulcers is anti-proteinases. So what happens in an ulcer is the eye, in response to the ulcer, starts making these proteinases, and it's trying to heal the eye, and it kind of overshoots, and it can actually start to break down some of the collagen. And so the proteinases that, again, an eye has made in an effort to repair the eye can actually cause you more trouble. So, and on the next slide, I'll talk a little bit about melting ulcers, but sometimes we have to use some anti-proteinases, and some of the things that we've used in the past are serum, the horse's own serum, that's an anti-proteinase, and then some of the things that we use now more commonly are EDTA or acetylcysteine. So some of these corneal ulcers are pretty simple, not very deep, not melting, and we can treat those on the farm. We'll have you guys put the meds in usually 4 times a day if you can. But you can treat them on the farm. We usually come back in a few days, check and make sure they go in the right direction. And that's all there is to it. But some of them, the more serious ones, deeper ones, fungal ulcers, a lot of times we're going to encourage you to bring them in here. We place a subpalpebral lavage system, which basically is just a system that allows us to give medications to them every 2 hours without prying their poor sore eyelids open. And then sometimes with these more serious ones, we'll suggest that you let us bring in our ophthalmologist to evaluate them and potentially surgically correct them if need be. So here's some few more gross pictures. Some of the types of corneal ulcers that we see. So when an ulcer first starts, right, all it is it's an abrasion to the cornea, an injury to the cornea. But pretty quickly, you get some kind of bug in there causing an issue. So bacterial would be the most common that we see. Fungal, the horses normally have some fungal elements in and around their eye, and so those can get seated in the ulcer. Those can be a little bit more difficult to treat. A melting ulcer, so this is an example of a melting ulcer up here. Those can be bacterial or fungal, but that's when you get basically too much of those proteinases happening, and it will actually look like the cornea is just melting or oozing away. Those are really serious, and we usually encourage you to bring those in. Indolent ulcer is just going to be a non-healing ulcer, an ulcer that we're treating, the horse is getting its meds, and we're just not seeing the healing. We're not seeing the vessels come to it. We're just not seeing the healing process happen. Sometimes those need just to be stimulated. We'll use either a Q-tip or the backside of a scalpel blade to kind of scrape around the edges of that ulcer to just kind of get them started healing. But it really depends on how, if they're super deep, we're not going to be doing that. We're going to recommend that the ophthalmologist is doing that. This is an example of a stromal abscess. So that's actually where, and that particular stromal abscess won't take up stain because the epithelial layers are still intact, but then you have an infection underneath. So sometimes, like we were talking about the blackberry thorns, you can get a horse gets a blackberry thorn in the eye, he backs up, blackberry thorn stays with the bush, but some bacteria got sited into that cornea. Epithelial level's over, but you've got an infection in there. And those can be pretty serious too, so we're usually referring you to ophthalmologists for those. And then a dysmetocele, this is going to be a dysmetocele over here, and excuse me, I'll show you guys in the next slide. So this is Descemet's membrane, which is the very last layer before you get through the cornea. And so once you get all of the layers here, all of the stromal layers, all of the epithelium, all gone, and you're down to Descemet's membrane, you've got one tiny layer between you and a ruptured eye. So those are for sure we're going to, refer you, and there's still a very good potential that the horse is going to end up with a rupture of that.
The difference between an ulcer and an abscess?
So the abscess is basically just covered still. So the epithelial layer is still there, and then the abscess is in the stroma here. And they're harder to treat because the epithelium is covering it, so it's harder to get the medication going.